we are now moving to the second session,
So
and the experts of second session
on the same day then before starting the stimulation. Jatin,
Sorry?
sir.
Yeah.
Do you depend on the E2 levels on the same day then day 2 to start your stimulation?
No, we don't give the OC pill, so there's no need to check anything.
Supposing there is a 11 millimeters there, and I mean, what do
No, so I'll give 3 days of antagonist, then recheck on day 5. If she still has a cyst, then I will do E2P4. Usually the cyst regresses. If it is 11 mm, it's hardly a cyst. It's more likely to be just a kind of dominant follicle. And we want to suppress that dominant follicle and then make it regrow from day 5. So that it's a uniform cohort.
So now I would like to welcome our next experts. So first, Dr. Tarini Taneja, ma'am. Welcome, ma'am. She is a known name in our society. She is a gynecologist IVF specialist and practicing in Muzaffarnagar since for more than 40 years of experience and a gem of a person. Welcome, ma'am.
Thank you so much for the kind introduction. Thank you so much.
So next is Dr. Poonam Goyal, ma'am. Is she here, Poonam, ma'am? I think she was not able to join. So next, Dr. Aruna Saxena, ma'am. She is done her MD from Lucknow, founder and director Orchid IVF Indirapuram, consultant Apollo Cradle Hospital and Cloud9 Parpadganj. Her area of interest is infertility, clinical embryology, and trained at National University of Singapore, and proud recipient of DGF Teaching Excellence Award in 2017. Welcome, ma'am. So next, I would like to welcome Dr. Shivani Goar. We all know her, a very vibrant person. She is the founder and director of SCI Healthcare and Multi-Speciality Center. And she has been practiced as an obstetrician gynecologist and infertility specialist for past more than 20 years. She's completed her qualifications in Mumbai and was involved with treating the first cases of legal surrogacy in India. She spent more than 4 years in United Kingdom as an IVF clinical research and practiced at Royal Infirmary of Edinburgh. Then in 2007, she returned to Delhi, and she has a distinguished work and brought local and international attention to SI healthcare IVF programs. Welcome, ma'am.
Thank you. Thank you, Megha. Thank you so much. So many times you have called and sent messages. I really appreciate you. Thank you.
Thank you, ma'am, for joining. Thank you. It's an honor for us. So next, I would like to welcome our speaker, Dr. Jatin Shah. Welcome, sir. It's an honor listening to you. I must say that each and every sentence what sir says is worth understanding, listening, and incorporating in your brain, because his lectures are to the point but very important. Thank you, sir, for joining, and our whole DGF family is very honored to listen to you now. So he would be speaking on Hypo-Responder. Can we do something to improve the results? Welcome, sir, and over to you.
Thank you.
One word more about him. He is the champion of IVF failures, and always he speaks and shares his own experience. And I think that is the beauty of his presentations.
Thank you, madam. Can you stop sharing? Then I can start.
Stop sharing.
All visible?
Yes, very
yes.
nice.
Okay. So thank you so much, everyone. Dearest chairpersons, Dr. Tarini, dear friend, Dr. Shivani, Jyoti. It's so good to see everyone. Of course, Dr. Seema, Dr. Jyoti Malik, for inviting me here today. And I think I must be setting some kind of record on this lecture, because I think I've spoken it almost 30-40 times over the whole COVID pandemic. But I asked Jyoti, do you have an alternate topic? And she said, no, we want to hear the same thing again. So then here it is. And we are going to talk today about poor responders, hypo-responders, and how to go about treating them in the best possible manner to give them a healthy genetic live birth. And why is it so important? Because if you look at this data here, we know that almost 60% of worldwide IVF clinics have reported an increase in the incidence of poor ovarian responder. And all of you would agree that this is true for us too, that almost 50% of the patients coming to us today fall in one of the categories of either Poseidon 1, 2, 3 or 4. So this is a huge epidemic within the times of our pandemic, and that is the epidemic of the poor responder. And you can see here, to keep it simple, we have Poseidon's group 1 and 2. Those are young and old patients who start with a normal ovarian reserve. So they came into you with a normal AFC, normal AMH, young or old, and you expected a good ovarian response, but somehow they did not respond well. They either gave you less than 4 oocytes or 4 to 9 oocytes, which was rather suboptimal, and therefore they fall in the unexpected group. Now in the unexpected group, you were not forewarned, so you couldn't do any kind of pre-treatment. And then you have Poseidon 3 and 4, which are young and old patients who come to you with a reduced ovarian reserve. So you have a 28-year-old with an AMH of 1 or a 42-year-old with a low AFC and an AMH of say 0.5. So these are all the expected poor responders. And together, these 4 groups, I feel it's even more than 50% of my current practice falls into these groups. And if they are highly educated and understand what is a biological or a genetic child, it's not easy to just tell them, okay, go for an oocyte donor. They want their own biological offspring. And that is where the challenge lies, that how do you go about giving them the best and hoping for a successful outcome. So of course, we all know that how do you diagnose a poor responder? You have to use criteria of age, BMI, how did she respond in the past, what is the antral follicle count, what is the recent AMH level, does she have associated PCO or endometriosis, and then you would classify her either as a potential high responder, a normal responder, or a Poseidon 3 and 4 group. Very important picture which I picked up recently from one of the ESHRE lectures. When we look at implantation as 100%, the uterus contributes probably 10%, whereas the embryo is 90%. And that is why our oocyte donation pregnancy rates are so high, because you give a young egg, a young competent egg, you give a top quality embryo, and therefore your implantation is much higher. But if you look at that 90% of the embryo, 80% is the oocyte. So that is why it is so important that how you go about pre-treating, how you stimulate the ovaries, how you trigger the ovulation, and how you do your IVF or ICSI, which finally will determine whether you get success in a poor responder. And here you can see how they clearly showed that the oocyte transmits not only the mother's nuclear, but also her mitochondrial genome to the embryo. And we know that mitochondrial DNA is known to be especially susceptible to aging, which is why, many a times we just keep jumping into doing PGTs for all above the age of 35. And then you find that even with a so-called normal euploidic blastocyst, the patient did not achieve pregnancy. That is because you cannot correct mitochondrial DNA in that same normal euploid embryo, which would contribute then to failure or to reducing the live birth rates. And here you can see why this is so. Even when you look at a typical heart muscle cell, which needs constant energy supply for heart through your entire life, it has say about 5,000 mitochondrial copies. But when a follicle gets recruited, mitochondrial DNA increases from 6,000 to 200,000 copies. And it is during this multiplication process that they are most vulnerable to mutations, deletions, which can then result in chromosomally abnormal eggs or embryos, which in turn will give you failed implantations, chemical pregnancies, miscarriages, and abnormal babies. So this is all much more likely when the engine of the egg cells are old and or low on energy. And that is why we need to now focus on mitochondrial integrity of oocytes in poor responders so as to give them the best outcome. Now, does the number of eggs retrieved affect pregnancy rates? And this is very important because we just saw Jyoti show a very good study from 2008 by Blockhill, I think 2011, where he showed in normal responders, the antagonist treatment did not give a higher number of oocytes, although there was a difference of 9 and 12. So does this 9 and 12 really make a difference to the final pregnancy rates? And that's a very interesting aspect we need to see. So here you can clearly see that the more eggs that you get, the higher is the chance of getting top quality embryos on day 2 or day 3. And this was a huge study of almost 300,000 IVF cycles, that the group with the most oocytes aspirated had the most top quality embryos on day 2, day 3. So in order to get one good top quality embryo, on an average, you need 3 metaphase 2 mature oocytes. So you can see that if you want, like the cutoff number of mature oocytes was 3, 5, 5, 6, and more than 6 for obtaining 1, more than 2, more than 3, more than 4, more than 5 top quality embryos. So this is very important, that to get one top quality embryo, you need at least 3 metaphase 2 oocytes on an average. Also very important is that with age, especially in your Poseidon 4, you can see here that with increasing age, you need more and more number of oocytes, which you're not going to get that one normal euploid embryo. So for a young patient, you may need, say, just about 9 oocytes. 38 to 40, for the same one euploid embryo, you would need on an average 14 oocytes. 41 to 42, you would need 32 oocytes. And for above 42, you would need 80 oocytes to get that one euploidic embryo. What about aneuploidy rates with diminishing ovarian reserve? Now we know that in the elderly patients, of course, aneuploidy rates will increase, but there is some good news here that in Poseidon group 3, that is young patients with a reduced ovarian reserve, where we have a mental perception that, oh, the eggs will not be good. This is not true. Your numbers will be lower. The blastulation rate and live birth rate will be equivalent to women with normal ovarian reserve. So there is no increase in the rate of aneuploidy. You will get fewer embryos, which you will need to accumulate to get 2 or 3 top quality ones before you do an embryo transfer. But you can rest assured and counsel the patient that this will not increase the chances of aneuploidies or abnormalities in the embryo. Again, the important slide that does getting even one extra oocyte. Now, mind you, we are not talking of normal responders. What we heard in the earlier presentation, in the excellent presentation, was a lot of studies in normal responders. We are now talking of poor responders that does one extra oocyte, and the pre-treatment have a significant impact on your final outcome. And you can see here, with every additional oocyte that you get, you have a remarkable increase in the live birth rate per cycle. So don't take it for granted that, oh, whether you get 2 or 3 or 4, it's the same. It's not the same, and you are affecting the final outcome by every means that you use so as to get even that 1 or 2 extra metaphase 2 oocytes. How do you avoid iatrogenic? Now, you know, Poseidon 1 and 2 started off as normal people, with normal AMH, normal AFC, young and old patients. You expected a good response, and somehow you did not get the right response. So this is where preventing iatrogenic Poseidon 1 and 2 is very important, and therefore the initial dose of FSH is of prime importance. And look at these studies here from 2018, clearly showing that you get higher number of oocytes with 200 versus 100, higher with 200 or 225 versus 150. So don't use 150 as a starting dose. Even if you have a thin, lean, normal responder, you now have the agonist trigger with you, so you really don't have to worry about OHSS. You rather have to worry about making a normal responder into a Poseidon 1 or 2. But that doesn't mean you go to 300 or 450 or 600 for every patient, because when you go about 225, there is no significant difference in the number of oocytes retrieved. So this is very important, that across all spectrums, of course, it could be higher for some poor responders or high BMI patients, but your minimum standard starting dose across normal responders, expected normal responders, should be 225 and never anything lower than that. So let's start with management of Poseidons 1 and 2. What can you do here, and what are the reasons for Poseidons 1 and 2? First, I told you iatrogenic. You gave her a low gonadotropin starting dose. Obviously, in the next cycle, you will need to step up her dose. Second, presence of polymorphisms. We recognize now that almost 10 to 20% of these patients might be carriers of FSH receptor or carriers of the LH beta variant, which makes the ovaries unresponsive. Means they have enough follicles, you gave her enough of a dose, but yet she did not respond because of these polymorphisms. Fourth, of course, problems with the trigger. Maybe the trigger was inadequate or something, and therefore you had 10 follicles, but you got only 4 oocytes and so on. But the most important, especially for the antagonist protocol, is asynchronous follicular development. And this, I keep stressing again and again, is the most important reason. Remember, in a normal responder, your pre-treatment may not make a huge difference whether you get 12 or 14 or 13 eggs. But in a poor responder, as you saw, 2, 3, 4 or even 5 eggs will make a huge difference to her final outcome. And therefore, your focus has to be on achieving follicular synchrony. Before we move on to that, what about high doses? You know, in the past, we often heard about a decade ago that if you go too high with FSH and HMG doses, you may increase the aneuploidy rates of the embryos. But I will show you in a short while a study which proves that that is not necessarily so. So here you can see all you need to do in the next cycle is increase your dose by 50 to 75. So you don't need to double. If you gave her 225 and you got 7 oocytes, you just make it 300 and you're likely to get more than a dozen oocytes the next time. So you can see here, just simply stepping up from 225 to 300 will give you a remarkable increase in the number of oocytes oocytes that you retrieved. So this is very important that all your decisions and doses should be scientific and not knee-jerk reactions to, just trying to double it and say, oh, let me get 20, 30 oocytes by doubling the dose. It doesn't work that way. And you can see here again, they did a study 150 versus 300 just to study aneuploidic rates, and they found clearly there was no increase in aneuploidic embryos by going up to 300. 63% euploid embryos in the 150 arm and 75% euploid embryos in the 300 arm. So they concluded that going higher with doses doesn't increase aneuploidy rates. If you get more oocytes, you will get more euploid normal embryos. So that brings us to that important part of how to achieve synchrony. And this is very important. You already saw this in the previous lecture. Luteal estradiol valerate 2 milligrams BD from day 25 until the day before FSH begins, that is the 24-hour washout. And you can even start stimulation as late as day 8 or day 9. So for those of you who just want to go on a 1 week vacation or avoid a weekend, you don't need over suppression with the OC pills or with progesterones. You just use this very simple means to achieve. And this is what we did for a whole 10 to 15 years before we switched to the antagonist about a couple of years ago. Second, of course, norethisterone, OC pills, we've already heard enough and discussed enough on this. But my personal favorite for poor responders and for normal responders and for all egg donors with regular cycles is now to give the antagonist on days 2, 3, and 4. And you will see a dramatic difference. In 30% of your antag patients, you will see that one follicle becomes dominant. If you start, say, day 2 morning or day 2 evening, or sometimes even day 3 or even day 4, thinking nahi, koi farak nahi padta, it's okay, you can just start. That is where the problem lies. So no shortcuts. Either you start early day morning day 2, but a lot of patients have recruitment of the dominant follicle in the luteal phase of the previous cycle. So even day 2 is too late to prevent follicular dominance. And that is where the antagonist works wonders. You just give antagonist. Also, many a time, suppose it's a Sunday and the patient can't reach you. Then she comes on day 3. So these are small practical tips. All you need to do is that when she comes the first time, you pack up 3 antagonist shots for her and tell her that you take this on day 2, day 3, day 4, and you meet me whether on day 3, day 4 or day 5, it's all fine, so that she doesn't panic, you don't panic, and you get your perfect follicular synchrony. You then begin stimulation from day 5. Now here you can see Blockil in 2011, the same study which Jyoti showed that there was no probable difference in the ongoing pregnancy rates. But what we are interested in, the poor responder, is number of oocytes, because we know every additional oocyte will increase your live birth rate. So here you can see 10 versus almost 14, and this achieved statistical significance. So it was important that the number of oocytes were higher, and in a normal responder probably it didn't make, although if you look at the pregnancy rates, 33 and 42 to my mind is quite a huge difference. But just because it did not reach statistical significance, we felt okay, maybe it's not of any use. But if you see the number of oocytes, there is a definite statistically significant increase when you do antagonist pre-treatment for the first 3 days before you begin stimulation on day 5. What about the use of the agonist? We've all just dumped the long agonist protocol, except some people who still do batch IVF and take the risk of OHSS. But otherwise, everybody seems to have switched almost 10 years ago to the antagonist for various reasons. If you look at this study from 2019, comparing agonists and antagonists in fresh embryo transfer cycles, you can clearly see higher number of oocytes, more embryos, higher clinical pregnancy rate, and higher live birth rate in the agonist arm as compared to the antagonist. Now again, you can see here from 5 oocytes, it went up to almost 9 oocytes. And it was those 3 or 4 extra oocytes which then pumps up the live birth rate in poor responders. So this was one study in 2018. And why does the agonist do better? The main point here is synchronized follicular development. So if you will all agree that when we did batch IVF, we never had this problem of one follicle becoming large and the others lagging behind. Somehow they all seem to be in the same 17 to 19 range when we gave the trigger, and we used to always get a good crop of eggs. But then we had the hyperstimulations in the high responders, and then we said, oh, no, this protocol is not good. Now let's just switch to the antagonist. But isn't synchrony what you want in a poor responder? Also, we felt that there were higher number of oocytes and embryos, and therefore too much of OHSS, and again we dumped it. But isn't that what you want in a poor responder? So poor responder is not going to have OHSS. If instead of 3 eggs, she gives you 8 eggs, she's not going to have OHSS, but you get a more successful IVF cycle. What about direct impact of the analogs on oocytes and embryos? And you can see here with the agonist, higher number of follicles, higher number of oocytes, lower number of oocytes with cytoplasmic abnormalities. Also, you have fertilization rate is much higher. Normal pronuclear morphology is also higher. These are all statistically significant differences, except the pregnancy rate, which did not reach significance. But again, 28% and 38% is different when you actually come down to the number of extra pregnancies that you will have with the agonist protocol. So isn't all this better in a poor responder, that when you get more oocytes, more embryos, better morphology and higher live birth rates, why would you still want to use the antagonists for all these patients? And here you can see now when you see agonist versus antagonist, and you can see here we did a study in the same patient. So the best control is always the same patient. We did one cycle with the antagonist with a combination of REC, FSH and HMG, and the other cycle with the agonist, preferring to use HMG or a combination of FSH, LH right from the beginning. And that is the trick. When you use an agonist protocol, you have to give LH from the beginning in these poor responder patients, assuming that they are polymorphisms or they will not respond well or they are low on androgens because of the age factor and all that. Best to always give LH right from the beginning. And you can see higher number of oocytes, but the most important difference was almost double the proportion of top quality grade 1 embryos. So that is why it's so important that if you are getting instead of 17.5%, 30% top quality embryos, you definitely will have a higher pregnancy rate. And these were all Poseidons 3 and 4. You can see low AMHs, low AFCs, and a short small study of 36 patients to prove the point that the agonist probably gives you better outcomes in this. But of course, a word of caution, you have to remember that agonist should never be used for high responders. Even for normal responders with a little high AMH or a very good antral follicle count, or if they are thin and lean, or if it's their first cycle, please err on the side of the antagonist and don't use the agonist and get caught up with an unpredicted OHSS. So very important, especially for those of you who are new, that don't just take home a message that, oh, switch back to the agonist. That's not what I'm saying. But for some poor responders, it could make the difference between success and failure. What about hypo-responders? Now, this is, of course, the group with the genetic polymorphisms, and we know that they also, there's a discrepancy. So you saw 10 antral follicles, but you got only 4 follicles which grew, and so on. And these are the patients who have polymorphisms, and what you need to do for them, you know here that, okay, either you test it and show that she is a GEG or a GA or a G allele or whatever. So some of these patients, they have with polymorphism very high consumption of FSH, or they have a very slow response. Day 7, day 8, day 10, day 12, follicles are stuck at 12 millimeters and you will just not budge however high you go with the FSH dose. Probably a lot of these patients need LH from the beginning, or they need the use of REC FSH instead of HMG to get a more potent FSH with less batch to batch variation and give you a better response in these patients. So this is another area where you could argue that, okay, maybe you start with the standard dose, instead of 225 even go to 300 if she's a suspected hypo-responder, and this should counteract the vast majority of the polymorphisms. But more importantly than just stepping up FSH doses, you need to remember that LH supplementation for these patients is very important right from the beginning of stimulation. What about Poseidon 3 and 4? Now remember, these are patients who don't have follicles. So if you're going to just keep on bombarding them with high doses of FSH, it's like flogging a dead horse. There are no follicles, nothing is going to grow. But what are the treatment options? Again, we have to consider the various agonists, HMG, and so on. So again, you can see here 2018 agonist versus antagonist for Poseidon's group 3, that is young patients with a low ovarian reserve, and they clearly showed a doubling of the pregnancy rates, live birth rates with the use of the agonist protocol as compared to the antagonist, again because of proper follicular synchrony. So you got all mature oocytes and more top quality embryos. How high should you go with the doses in this group? And beautiful study was done long back 2010, comparing 300 versus 450 versus 600, and as expected, there was no difference in the live birth rate. So there's no point going beyond 300, and in fact, however high you go with the dose, your outcome will usually be the same. And in fact, there are papers which say that even just 150 is enough, because if she has just 2 or 3 follicles, why do you need 300 or 450 of FSH? You can just give 150 and those 2 or 3 follicles will grow and give you the oocytes. LH supplementation, again, we know all elderly women should take from day 1. Hypo-responders, if in the past they've been a slow response, day 18, day 20 triggers, you start from day 1 in a subsequent cycle, or at least add on LH from day 6 or 7. Of course, patients with hypogonadotropic hypogonadism, you must start with 300 IU of FSH and 300 of LH. Poor responders, some groups initially said that addition of LH does not improve the response. The same groups subsequently have published papers showing an increase in the pregnancy rates with the addition of LH. So of course, this was the classic PERSIST trial for elderly women, whether you should give LH from day 1 or from day 6. And clearly, day 1 group had much higher pregnancy rates at 31% as compared to 17% if started from day 6. And a more recent study, 2021, published here about recombinant LH supplementation. When you make, they classified patients into mild, moderate, severe, poor responders according to a prediction score that they had, and they clearly showed that LH supplementation has a significant effect on increasing cumulative live birth rates in moderate and severe poor ovarian responders. What about the trigger? Very often you see a lot of follicles, but you don't get enough oocytes, or you have lot of oocytes, but very few metaphase 2s, or you have 4 or 5 metaphase 2s, but you just got 1 or none top quality embryos. This is often related to the final trigger. Now remember, in a natural menstrual cycle, the final oocyte maturation is induced by a dual increase of both LH and FSH. Very, very important that even FSH increases in a natural menstrual cycle. Give our good old favorite HCG trigger, we only simulate LH activity. So when you give an agonist trigger, you are again mimicking nature, and you are getting a proper endogenous FSH and LH surge, thereby mimicking and getting much better conversion to metaphase 2s. In fact, nowadays we've stopped giving HCG to a lot of patients. Wherever you feel even a borderline risk of OHSS, you safely give the agonist trigger. Of course, you have to do a freeze-all, you can't do a fresh transfer, but you are absolutely safe and nothing happens to the patient. So in poor responders, remember that you sometimes might need to use both. So if you have a patient where you had fewer oocytes retrieved as compared to the number of follicles, when you use a dual trigger, that means you give both HCG as well as the agonist, you will see significant improvement in all the outcomes, number of oocytes, number of top quality embryos, number of embryos transferred, and ongoing pregnancy rates. Everything is better with the dual trigger. So also if you get 10 oocytes but only 4 metaphase 2s, again with the use of the dual trigger, you will restore all the parameters to statistically significant better outcomes when you give a double trigger as compared to just giving HCG alone. And here you see specifically for poor ovarian response what we are talking about today. The study group which received both REC HCG as well as 0.2 of triptorelin, that is the dual trigger, you see clinical pregnancy rates up from 20 to 33%, live birth rates up from 14 to almost 27%, reduction in miscarriage rates, and overall much better outcomes in poor responders with the dual trigger. What about mild ovarian stimulation? I have not really been a fan of mild ovarian stimulation, and only for this reason. If you see here, when you compare the number of oocytes with mild, on an average you just get 1. With conventional antagonist and high dose FSH-LH, you would get 3, statistically significant, and as I showed you earlier, getting 2 more oocytes is a huge difference to the final outcome of the patient. Very important study here from 2020, which again showed that when you have less than 3 antral follicles, there is no significant difference between mild and conventional stimulation. But whenever you have an antral follicle count of more than equal to 3, mild does not give you the same outcome as compared to a conventional regime. So it's important that the conventional antagonist protocol with supplementary LH is more effective than the mild one for patients with a diminished ovarian reserve. Again, should you convert to an IUI? So many times I come across patient files where, oh, I didn't respond well, I had only 3 follicles, so doctor converted me to an IUI cycle. There's no logic to this. If this patient is not going to give you 10 follicles in the next cycle. So whenever you have 2 or more follicles, clearly you will get a higher pregnancy rate with IVF than converting her to IUI. So only if you see only 1 follicle, then maybe IUI and IVF may be the same. But if anyone has 2 or more follicles, IVF will definitely give you a higher live birth rate. So please don't just convert IVFs to IUIs if they show a poor response, because she is not going to dramatically increase the number of follicles in a subsequent cycle. And whatever you have to play with is just those 2 or 3 follicles. What's new for the poor responders, and that is where dual stimulation, you know that a lot of women have 2 waves of follicular recruitment in a 28-day cycle. A lot of women have 3 waves of follicular recruitment, and dual stimulation by conjugating follicular phase stimulation and luteal phase stimulation allows you to maximize the number of oocytes obtained in a short time frame. Now, of course, a lot of you would argue, okay, what is the hurry? You can easily do it back to back, but there is some scientific logic to it besides the psychological advantage. One, as this study by Ubaldi showed in 2020, that 100 patients who started off, the main thing he noticed, the cumulative live birth rate increased from 7% after follicular phase stimulation to 15% after dual stimulation. And this is because he compared dual stimulation with conventional stimulation patients. The conventional ones were also told to come back for a second cycle, but only 17 of those patients who underwent conventional came back for a second stimulation. So there was a dropout rate of 81%. Whereas in dual stimulation, the patients were already committed to 2 stimulations in a month, and all of them completed it. 91 patients completed the whole entire dual stimulation. And this is why when you commit the patient for 2 stimulations, you not only give them a higher chance, you also get more oocytes. But what is more interesting is that somehow the luteal phase derived oocytes probably sometimes are better. So you can see here follicular phase versus luteal phase stimulation. Higher number of oocytes, higher blastulation rates, higher number of blastocysts. Very, very important, although the final ongoing pregnancy rates again here did not reach statistical significance, but 42 and 54% was quite a difference. And how do you do it? And this is how most groups do it. We give gonadotropin from usually your day 2, day 3 antagonist protocol, add antagonists say on the 5th or 6th day of gonadotropin, then give a trigger. Now the trigger is controversial. Should you give HCG? Should you give just the agonist? I prefer to give just the agonist, triptorelin 2 milligram, 0.2 milligram, and do the egg retrieval at 36 hours. We then wait for a couple of days and then again start. But now if you have used, what I like to do is use HMG and REC-FSH combination in both follicular phase and luteal phase stimulation, although Yankun study here used only FSH in the follicular phase and only HMG in the luteal phase. Now they will not have a second premature LH surge, so there is no need to give the antagonist in the second half. All you need to do is give MPA, because otherwise she might have some troublesome menstruation just a day or 2 before the egg retrieval, and that can upset the patient emotionally, although it makes no difference. If you do a pickup even during her menses, you will get very good eggs and make good embryos, but psychologically it's not good. So we give MPA when you start the luteal phase stimulation just to prevent the onset of menstruation. You will not get a second LH surge, so no need to give the antagonist here. There are some groups now which say that it's best to use MPA right from the beginning, because anyway you're not planning a fresh transfer, and to reduce the injection overload for the patients, that could be a much better and viable option. Now what did this study notice? And you can clearly see again the luteal phase stage embryos pregnancy rate was 47%, whereas follicular phase stimulation embryo pregnancy rate was just 26%. So this group showed a statistically significantly increased pregnancy rate with the use of luteal phase stimulated embryos as compared to follicular phase stimulation. And our own initial experience was unbelievable. But as expected, with time and with increasing numbers, the pregnancy rates went down. But initially, we did just this pilot study of 20 patients. This was just at the time, just before the COVID pandemic. And we selected embryos for transfer as per which were better. So in the follicular phase stimulation, 4 out of 20 patients used follicular phase stimulation, whereas 16 patients out of 20, that is 80%, had better embryos with the luteal phase stimulation. 2 out of 4 pregnancies here, 13 out of 16 pregnancies here, 3 out of 13 early miscarriages, still giving an ongoing pregnancy rate of 62.5. Right now, we are almost at 100 plus patients, and this has stabilized around 38 to 40%, which I still feel is extremely good compared to the otherwise 10 to 20% that we used to get with conventional protocols for these very poor responders with very low AMH levels. So something really worth considering. Of course, there are some challenges that do you really need to give the antagonist? Can you give MPA throughout? What is the best day to start the second stimulation? I give a cap of 2 days. Some studies say 5 days. Some studies say next day. What is the ideal drug for triggering? Because if you give HCG in the follicular phase, you will have persistent corpora lutea with high progesterone levels. Will this affect the oocyte quality? We don't know, and so on. So a lot of things still need to be sorted out. But at the moment, it seems that at least there is some ray of hope for the poor responders. Very neglected area is the use of adjuvants, and we know that with increasing age, there will be a reduction in testosterone levels in women. And you know that androgen receptor expression is important at every stage, especially pre-antral, antral, and maturation of the oocyte. And it's very important to have adequate androgen levels for these poor responders. DHA came with a bang, probably will go with a whimper, we don't know. Initial studies showed miracles. Again, the 3 largest RCTs have shown that there doesn't seem to be a great effectiveness with the use of DHA pre-treatment. What could be better, maybe the use of direct testosterone rather than using DHA. And we have studies here from 2014 where pre-treatment for 3 to 4 weeks increases the AFC, ovarian stromal blood flow, and improves the ovarian response. And you can see here increased live birth rate, typical pregnancy rate, and so on. But most of these studies gave just 20 to 30 days of transdermal testosterone. And if you look at basic physiology, we know that the time duration, like these other studies, all giving for 15 to 21 days. But if you actually see, secondary to antral follicle is actually 71 days. So if you really want to see the benefit, you need to give it for an extended period of time. So we are hoping that the results of this trial, the T-Transport trial, where they have given 60 days of testosterone followed with the long agonist protocol and the use of HMG, which I stressed, the same protocol they have been using for for the poor responders. And we will wait to see the outcome of this trial to know whether 60 days is the way to go, what should be the dose to prevent hirsutism and all the other androgenic side effects, and how we should go about giving it. Of course, letrozole also very important androgen modulating agent, especially for elderly women, because it helps to restore androgenic ovarian environment. And you can see here 5 milligram letrozole given from the first day of stimulation until the day of the trigger, and clearly a reduction in peak E2 levels, which is good, because if supraphysiologic levels will reduce endometrial receptivity for fresh transfers. So that's good. Number of oocytes significantly higher, number of M2s are higher, number of top quality embryos are much higher, and you get better pregnancy rates with this kind of an approach. Growth hormone, expensive, lots of to and fro going on. Does it work? Doesn't it work? And so on. And you can see here that this was, of course, the largest study done by Norman and presented 2016 ESHRE, where he showed no significant difference in live birth rate in poor responders of growth hormone. Finally, of course, oxidative stress is also very important. And as I told you, insufficient coenzyme Q levels, ubiquinol levels will cause a lot of problems and mitochondrial damage and dysfunction in the oocytes. This was by Rodriguez in 2021. And we know that when you give antioxidants, myo-inositol here was given in one study, but if you give 200 milligrams 3 times a day for 60 days preceding the IVF cycle in Poseidon group 3 and 4, where we are prepared, you will get a higher number of retrieved oocytes, fertilization rate, and higher quality embryos than in non-treated women. Very important study that I picked up while researching was, can you actually reverse the biological clock? Till now, we keep saying you cannot reverse the biological pelvic clock, and some ray of hope here. These were, of course, done on in a mouse model. These are young ovaries. You can see healthy, nice and pink, lot of antral follicles seen. Old, shrunken, atrophic ovaries as expected. Old ovaries after 15 weeks of coenzyme Q pre-treatment, and you can see it's almost restored to the same as a young ovary, and you get significantly higher number of follicles and significantly higher number of oocytes in these ovaries, which get converted to this with just 15 weeks of coenzyme Q treatment. So something to study, something to research. We need to use for about 60 days, of course, preceding the cycle. You can't do it in groups 1 and 2 because they didn't expect them to be poor responders. But for Poseidon 3 and 4, this would help in improving all the outcomes associated with successful IVF. And you can see here, improves the ovarian response, restores oocyte mitochondrial integrity, increases the number of cumulus cells. Even addition to culture media has been shown to improve oocyte and embryo quality, and proven to partially revert oxidative stress damage in oocytes of even younger women. So these were, of course, a lot of studies were there. Most of them used it for 2 months, and they showed a reduction in aneuploidy rates in older patients. Even in IUI cycles, they showed higher antral follicle count and more mature follicles in poor responder patients who want to go in for IUI before going in for the IVF. What about inositol? We all know about inositol in PCOS and how it will help and so on and so forth. But here there is an interesting study in normal and poor responders. And again, they showed oocyte quality, embryo quality, and clinical pregnancy rate significantly higher. Abortion rate significantly lower. Proportion of top quality embryos significantly higher. GV oocytes significantly lower, and consumption of gonadotropin significantly lower in the myoinositol pre-treated group. So some role maybe for myoinositol even in normal and poor responders, and not just in your PCO patients. Again, vitamin D is very important as a supplement for poor responders for better outcomes, and so is zinc, which also improves meiotic and mitochondrial competence. Finally, of course, before we end, we have to think about laboratory, because I always hear, oh, she has only 3 oocytes. I think ICSI will be better. Oh, she's about 38 years old, 40-year-old. I think ICSI will be better. So please don't just assume that ICSI is better for these patients. It's not, because we know for a fact, you can see here, that ICSI doesn't really work. And you can see when you compare IVF and ICSI, even in women with advanced maternal age, you have higher blastulation rate with conventional IVF and same fertilization rates with both. So don't be under an assumption that elderly women require ICSI and so on. Again, you can see so many studies clearly showing that there is no benefit, no proven study to prove benefit of ICSI in poor responders and elderly women. PGTA, of course, it will probably reduce the emotional trauma of miscarriages by eliminating aneuploidic embryos, but the live birth rate is the same. So it will not increase your live birth rate, it will only eliminate early miscarriages. We have to balance it against the costs, higher workload for the lab, and so on. Is there a link between diminished ovarian reserve and early miscarriages? Yes, we now know that patients with low AMH could probably, although we feel the aneuploidy rates are not high, but like I told you, everything is not genetic. What about mitochondria? And you can see here tendency to lower, higher miscarriages with low AMH and high FSH levels. That means women with poor ovarian reserve often will have higher recurrent miscarriage. You can see here low AMH, 2.7 times higher risk. Low AFC, again 2.5 times higher risk for recurrent pregnancy losses. So important area of research here. The future, of course, we all know about intra-ovarian PRP. This was the first study. Subsequently, they showed, this large study clearly showed improvement to 33% and 40% in the PRP group versus 10 and 15 in the control group. So for the future, we have a lot of exciting advances. And what if all fails? Of course, oocyte donation always works for most poor responders. So that is the last option. And prevention is better than cure. So please encourage the young women of today, the career women of today, to please freeze their eggs so that they don't have to be poor responders in the future, don't have to resort to oocyte donation. Finally, to summarize the guidelines as of today, agonist and antagonist equally recommended. CC alone or in combination with GnRH stimulation recommended, whereas letrozole not recommended. Now this was 2019, so the letrozole paper I showed you was after that. Higher dose of 300 recommended over 150 for groups 1 and 2. Dose of 300 over 150 not recommended for groups 3 and 4. Modified natural cycle, mild stimulation, adjuvant growth hormone, DHEA, aspirin not recommended. Addition of REC-LH might increase number of oocytes. Dual stim as of 2019 not recommended because there are not enough studies, and as they rightly said, you need more studies to show its benefit. So finally, light at the end of the tunnel, yes, for Poseidons 1 and 2, pre-treatment, ensure the correct starting dose, identify patients with polymorphisms, use higher doses of REC-FSH or add LH from the beginning or HMG, and judicious use of the agonist and antagonist. Poseidon 3 and 4, avoid overdosing, again agonist and antagonist, dual stimulation holds promise, ovarian activation holds promise, and oocyte donation when all else fails. So this is what I currently do, pre-treatment with coenzyme Q, resveratrol, ARG9, so on, testosterone for 20 days pre-stimulation, first choice protocol, long agonist with HMG, next cycle if that fails, then antagonist pre-treatment with the antagonist, dual stimulation if the patient agrees to it, and then frozen transfers. Of course, big thank you to my team. And once again, thank you, Dr. Seema, Dr. Jyoti, and the entire Delhi Gynec Forum for giving me this opportunity again and again to come and present at your meetings. Thank you so much.
Excellent, sir. Excellent. Thank you very much. Very, very much. It was such a good talk that I think each and every word was very important, and we have to imbibe that and use that in our practice. We all must be really spellbound, and I think nothing to I'm falling short of the words to praise you, and I think I have no words to say. We are so much obliged, so thankful that you have given time to us and you are there to teach us. So nice of you, and we hope in future also, like for 6 months, we can keep troubling you for our further series.
Not the same topic now.
No, sir. Definitely.
Up to unmute.
Now thin endometrium, recurrent failure,
Invite our experts.
all that will speak.
Yes. Now we invite our expert, Dr. Tarini ma'am, to say a few words. Dr. Tarini ma'am.
Dr. Shivani,
Yes. Dr. Shiva, yes, thank you so much for giving the opportunity. It's always magical talk of Dr. Jatin. We all know, we all trying to listen him. He always gives a very innovative ideas and new ideas as a research. I just wanted to know, Dr. Jatin, like for the poor or hypo-responders, we used to think that we give the long agonist protocol. It will suppress. So what about the experience about the short agonist protocol?
No, so very good question, and that's why I clearly said that in the agonist arm we start with HMG. So you cannot start with pure FSH. If you are using the agonist for the poor responder and if you use rec FSH, you are absolutely correct. The suppression will not allow follicles to grow because LH is also over suppressed. So the trick is to start with HMG directly. 300 to 375 directly you start with HMG and don't use pure FSH.
So can't we use the ultra short protocol? It will
Short
not
agonist
the
protocol.
synchronize the follicle?
No, but short agonist, there's always a risk of initial flare-up. When you give day 2, 3, 4, you will get flare-up. Suddenly a dominant follicle may shoot ahead. Again, you're back to square one. So if at all you want to use a short one, then it's the antagonist pretreatment and antagonist protocol without any OC pill pretreatment, or use the agonist protocol with HMG. So these two are the choices I showed you, personal choices.
Oh, okay, thank you so much. And what about the growth hormones in the women of the elderly age? If they are deficient of the growth hormone by the test of chlorine test, so
Yes.
is it like effective in those cases or not?
No, so if cost is not an issue, you can use because the papers keep bouncing to and fro. If you do a PubMed search,
The women, they are like women diagnosed with the deficient growth hormone.
Correct.
So can we
Of course you
add
can.
the growth hormone?
You can give 4 to 8 IU. Yes, you can give with FSH, not a problem.
Okay. So I'm really for dual stimulation. There are so many you also intricacies. When to do the second
Dual stim, yeah.
trigger in that case. In the second one, stimulation. In the double stimulation, should we give the trigger or not in the luteal phase?
No, of course you have to give trigger.
We have to give that.
Yeah. So what I do is in the follicular phase, I give the decapeptyl trigger, the agonist trigger alone. And then in the luteal phase, we give HCG with agonist both. Dual trigger.
You have to give the different trigger in both the phase, follicular and So it's a wonderful musical talk. I'm really learned so much from
thank
this.
you, madam. Thank you.
Thank you so much.
Thank you, ma'am.
Dr. Aruna.
Dr. Aruna. You're muted, ma'am.
Unmute yourself.
Aruna, you're muted.
Dr. Aruna.
Hi, Dr. Jatin. It is always so mesmerizing to hear your lectures. I just want to know about your experience about the Pargo, where is the fixed dose combination of recombinant FSH and LH.
Yeah.
How effective is it? Is it really a good idea to substitute it for HMG for those who can afford it?
You could try a few because I just tried 5 to 10 patients, not more.
Okay.
Cost is an issue because it's expensive compared to any of the other drugs, compared to Menopur, HP, Gonal, Recagon, anything. So as of now, I have not used enough for that. And when we are doing so well with, HMG and Rec FSH, Rec LH combinations, I have not got a chance to use too much of Pargoveris. On paper, it sounds like it should work well because, initially we used to use 300 of Rec FSH and 150 of Rec LH. So this is probably giving you the same combo, but I think we'll have to do at least 30, 40, 50 patients before we get to know whether it's working or not. The problem is, any new drug comes, we start using it for the worst of cases. So that is not the right way to know whether the drug is good or not. So initially you should always use it for a few normal patients and then start using it for the poor responders.
Okay. Dr. Jatin, earlier your talk on the same topic, you were using indual stimulation. You were using antagonists in the luteal phase as well. Am I right?
I was, yeah. That was all the initial teething problem.
But now you have shifted to Meprate in the luteal phase.
Yeah, now Meprate only because now we know there is no second premature LH search. I should have known it before, but it didn't strike me.
Thank you, Dr. Jatin.
Yeah. So actually, my son did all that research and he told me that, Dad, we don't need to give in the second half. So that's how it happened.
Inspired by you, I tried few cases of dual stimulation. Of course, I got very good number of embryos in the luteal phase, but unfortunately no pregnancy in whatever.
That's okay. It's a learning process. You have to wait. You will get. Don't worry.
Thank you. Dr. Shivani Goar. Shivani ma'am.
Dr. Shivani, Brigadier Sharma is all over to you, sir.
Thank you, Dr. Jatin. It was really nice seeing you after so many years.
Sir,
I would
same
say.
here, same here.
And it's a very nice lecture. And I think you have summed up everything and given a clear-cut, the treatment protocols for these poor responders. And I just want to ask you one thing. Testing for anti-ovary antibodies in these patients or poor responders, do you have any experience? And because
No, not really.
Dr. Firoza Parekh once upon a time used to talk about this.
No,
Yeah, so
test for
what is
everybody.
your opinion about that?
No, so they still test for everybody to the best of my knowledge, but I have never done that test ever. If at all cost is not an issue, then I just check for the polymorphisms. But otherwise, just seeing the ovaries, going by the past history, usually we can, fine tune what she needs as a start to avoid all those hypo-responder type of responses. So we don't really go into ovarian antibody testing at all. I have never done it in 30 years of practice.
Thank you.
Thank you very much,
Both
sir.
the talks have been absolutely wonderful. And I think we will give you the recording so you could go through these two presentations, especially of Dr. Jatin Shah, because I think 5-6 times you have to listen to them and then make up your mind what has to be done. So I think it has. Yes, Dr. Bali, you want to say something?
Jatin said it was a mesmerizing presentation.
Little louder, Dr. Bali.
1 second, ma'am. I will just increase the volume there. Beautiful presentation, sir, as usual. Just wanted to know your experience on microdose flare in poor responders.
No, I have never used that. That's why I don't show it. I only show what I use. So what I don't use, I don't show.
Anything you want to add on, Dr. Jyoti? If you are using something different, you can please share that.
We've used microdose flare long back, not off late, but it used to give us good results in poor responders. But of course, the sake of convenience is not there with that protocol. It takes quite a tedious time into the patient. So we've also switched over mainly to antagonist protocols.
Very nice of you. Thank you.
Dr. Jatin, do you use resveratrol quite often in poor ovarian?
All
It is very effective in male patients, but yeah.
No, even the female. For mitochondrial integrity, it works like magic. So we give a combination of ubiquinol and resveratrol 60 days.
Okay. And
I think a lot of studies have been there that this mitochondrial things environment has to be changed.
Yes.
And this particular salt is pretty good. Dr. Brigadier Sharma had a long time told us that all PCOD patients you should definitely give QQ10 in the dose of 300. And yes. I'm surprised that you have escalated the dose to 600 BD.
600 BD.
One message people should take it.
No, that is CoQ10. So ubiquinol is the active form where I think we give 100 BD, 200. That's it.
Yes.
Ubiquinol is the final active form of coenzyme Q10.
This particular salt has to be appreciated because there's a difference between this. Yes.
Melatonin and vitamin D3 too.
Yeah.
That's the addition to the adjuvant list for poor responders.
Yes, even melatonin, yes. I'll get that for my next time.
Yes.
So this comes to the end. Now, my sincere thanks to both the speakers for today, Dr. Jatin Shah and Dr. Jyoti Malik, and all the experts, Sharda ma'am and Dr. Sharma sir, Tarini ma'am, Sunita ma'am and Sunita Arora, Jyoti Bali, and all the panelists who has joined today, and all the members of Fertility Update and my colleague Megha and Archana and everybody. Thank you very much for joining in, and we are looking forward for the next CME or next of May. Thank you very much. Have a good day. And
Dr. Jatin Shah, one thing, I apologize again that you didn't want to talk on the same subject, but we wanted, Delhiites to listen. This
On a lighter
particular
note, I
talk.
was just making a joke. I love this lecture myself.
Again, a very
Yes, excellent.
actually,
The more we listen to it, the more we imbibe it. That is why we request you every time to repeat it. That
after
is,
every 6 months, we can listen again to you, sir. On
Yeah.
this.
Yeah, if you add
I
on
just
something.
gave
Sir, हम रट्टे मारना
my
चाहते हैं.
obstetric also.
Grab.
Thank you so much.
Thank you, ma'am. Thank you, and have a great day, ma'am. Happy, healthy life.
thank you,
Hamisha,
Dr.
Hamisha के लिए.
Ma'am.